In this chapter, we'll review the clinical approach to corneal ectatic disease. We'll cover the underlying pathophysiology, diagnostic evaluation, and management strategies for conditions such as keratoconus, pellucid marginal degeneration, and related ectasias.
Corneal ectasias are a group of non-inflammatory disorders characterized by progressive corneal thinning and irregular corneal protrusion, which leads to irregular astigmatism and visual impairment. The main examples include keratoconus, pellucid marginal degeneration, and keratoglobus. What differentiates these conditions is the specific pattern of corneal thinning, which ultimately defines the clinical features, the disease course, and the appropriate management approach.
Let's begin talking about keratoconus first. Keratoconus is a progressive ectatic disorder characterized by thinning and protrusion of the central or inferior cornea, resulting in a cone-shaped appearance. The prevalence is estimated to be about 1 in 2,000 individuals, though this figure varies depending on geography and testing methodology. It is more commonly observed in South Asian and Middle Eastern populations and shows a slight female preponderance. Family history plays a role, with approximately 6 to 8% of cases reporting affected relatives and a prevalence of about 3.3% in first-degree relatives. Importantly, first-degree relatives may also demonstrate subclinical tomographic abnormalities, highlighting the genetic influence. The clinical image provided illustrates the classic conical protrusion of the cornea that defines keratoconus, a hallmark feature of this condition.
Keratoconus is influenced by a variety of risk and contributing factors. Genetic predisposition plays an important role, often compounded by environmental influences such as frequent eye rubbing, allergic conjunctivitis, and atopic disease. Patients with hay fever, asthma, or eczema are at higher risk, with incidence rates at 30%, 23%, and 14% respectively. Additional risk factors include contact lens use and collagen abnormalities, such as Ehlers-Danlos, which is classically noted by its hyperelastic joints. In fact, about half of keratoconus patients have hyperelastic joints. Other contributing factors include prior ablative keratorefractive surgery in those with thin corneas or high myopia, as well as oxidative stress. The natural history of keratoconus typically begins around puberty, with the fastest progression occurring during the teenage years and early 20s. Progression tends to slow significantly in the fourth decade of life and is rare after the age of 40. The table in the upper right-hand corner highlights systemic and ocular conditions commonly associated with keratoconus, such as Down syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, mitral valve prolapse, sleep apnea, aniridia, floppy eyelids, retinitis pigmentosa, and vernal keratoconjunctivitis. Clinically, keratoconus should be considered in young patients who present with frequent prescription changes, progressive myopia or astigmatism, and vision not fully correctable with glasses. Keratoconus typically presents as a bilateral but asymmetric condition marked by progressive apical thinning and protrusion of the cornea, often in the inferior paracentral or mid-peripheral region. As the disease advances, patients experience worsening irregular astigmatism, which contributes to significant visual distortion. Importantly, keratoconus usually occurs without associated keratitis or neovascularization, although these complications may appear in those who wear contact lenses. Several clinical signs are characteristic of this condition. The scissoring reflex observed during retinoscopy is often one of the earliest but nonspecific findings, reflecting irregular astigmatism. In more advanced disease, the Munson sign may appear, where the lower eyelid contour deviates inferiorly when the patient looks downward, due to the cone-shaped cornea pressing against it. Another useful sign is the Rizzuti sign, where a pen light shown temporally produces a cone-shaped nasally focused reflex. The Fleischer ring is an iron ring at the base of the cone that can be partial or complete and is best visualized with a cobalt blue filter. Additionally, Vogt striae, which are fine, vertical, parallel stromal lines at the cone apex, can be seen but typically disappear with applied pressure. Apical scarring is another important and common feature that can take different forms. Reticular scarring results from breaks in Bowman's layer, while nummular scarring occurs at the cone apex and is often related to contact lens wear. Deep stromal scarring may also be seen and typically follows episodes of corneal hydrops. Together, these clinical findings provide a clear framework for identifying key features of keratoconus. The next two slides highlight the common clinical findings in keratoconus. In Figure A, we see apical thinning and scarring, which represent advanced disease. The cornea becomes progressively thinned at its apex, and repeated mechanical stress or episodes of acute hydrops can lead to scarring that further compromises visual clarity. This scarring is often visible clinically as areas of irregular opacity in the cone-shaped cornea. In Figure B, the Rizzuti sign is demonstrated. This sign is elicited by shining a penlight from the temporal side of the cornea, which produces a sharp, conical reflection on the nasal cornea. It occurs due to the abnormal protrusion and steepening of the cornea, which focuses the light abnormally. In Figure C, we see the Fleischer ring, which represents iron deposition at the base of the cone and can be partial or complete. This is best visualized under cobalt blue filter illumination, where the iron appears as a dark brownish ring encircling the cone apex. Figure D demonstrates Vogt striae, fine vertical folds within the posterior stroma at the apex of the cone. These striae are unique in that they disappear with gentle external pressure on the globe, distinguishing them from true stromal scars. Figure E shows the Munson sign, a late finding in advanced keratoconus. Here, the cone's protrusion causes a visible angulation of the lower eyelid when the patient looks downward. It is a classic but relatively uncommon sign, as patients are usually diagnosed before reaching this stage. Finally, Figure F highlights reticular scarring, a result of breaks in Bauman's layer. The white arrow indicates areas of discontinuity, while the black arrow shows collagen filling in these breaks. This scarring tends to develop after repeated episodes of stress, thinning, or acute hydrops, and contributes significantly to visual decline in advanced disease. Together, these figures demonstrate how keratoconus manifests not only as progressive thinning and protrusion, but also through distinct clinical signs that help in diagnosis and staging of the disease. The next slide shows an example of scissoring reflex, which may be seen in keratoconus. Acute hydrops in keratoconus refers to the sudden development of corneal edema caused by a tear in Descemet's membrane. This typically occurs in advanced keratoconus and usually later in the disease course. Importantly, it is not associated with spontaneous perforation. Several risk factors predispose patients to hydrops, including eye rubbing, allergic disease, and Down syndrome. Clinically, the edema often resolves spontaneously in about 3 months, but it can leave behind posterior stromal scarring, which has long-term visual consequences. Sometimes, stromal clefts, which are fluid-filled stromal pockets, can develop. These may close spontaneously, but they increase the risk of corneal neovascularization. The scarring and vascularization together can lead to significant visual impairment. Because of this, patients should be strongly counseled against eye rubbing, which not only accelerates the progression of keratoconus, but also increases the risk of developing hydrops. On the right, the clinical image demonstrates a case of acute corneal hydrops and keratoconus. The cornea appears markedly edematous with a cloudy and opaque appearance due to fluid accumulation after a Descemet membrane tear. When evaluating for keratoconus, clinical assessment may reveal irregular astigmatism and inferior corneal steepening. Keratometry can sometimes detect these changes, especially in upgaze, but its utility is limited. Central K readings greater than 48.7 diopters typically suggest keratoconus versus K readings between 47.2 and 48.7 diopters is considered probable keratoconus. However, more advanced diagnostic tools are necessary for reliable detection and monitoring. The cornerstone of evaluation today is corneal topography and tomography. These modalities are indispensable for early diagnosis, tracking disease progression, planning contact lens fitting, and guiding surgical decision-making. Several imaging methods are available, including placido-based imaging, slit scanning devices, and Scheinflick imaging,
with the pentacam being a common example. These technologies allow us to visualize subtle corneal shape changes and detect early keratoconus even before clinical signs become obvious.
Of note, corneal topography and tomography differ in the scope of information they provide. Topography maps only the anterior corneal surface curvature, producing color-coded power maps that highlight steepening or flattening patterns. While it is very effective for detecting anterior surface irregularities, it cannot assess the posterior surface or corneal thickness. In contrast, tomography evaluates both the anterior and posterior corneal surfaces, along with pachymetric mapping across the cornea. This makes tomography more sensitive for detecting subclinical keratoconus, as posterior elevation is one of its early findings, which corneal topography alone cannot identify. More so, its ability to detect abnormal thickness distribution before anterior changes become apparent makes tomography the better tool for detecting and monitoring disease progression.
When we assess keratoconus using corneal topography, there are several hallmark findings that stand out. First, we often see increased overall corneal steepening, typically when keratometry values exceed 47.2 diopters, as mentioned in the previous slide. One of the most characteristic features is inferior steepening, which is usually associated with abnormal elevation and thinning of the cornea in that region. Correspondingly, the superior cornea often shows relative flattening, which creates the classic topographic asymmetry. Another important metric is the inferior-superior ratio, or IS ratio. A ratio greater than 1.2 is considered significant and strongly suggestive of keratoconus. In addition, we evaluate the skewing of radial axes, or SRAX, which is elaborated on in the next slide. When this value exceeds 21 degrees, it suggests keratoconus. Normally, with regular astigmatism, we see a symmetric bow-type pattern on topography. However, as keratoconus progresses, this bow-type pattern becomes distorted and is eventually lost, reflecting the irregular astigmatism. It is important to emphasize that we should not rely solely on the power map of the cornea. Instead, we must evaluate the full corneal contour, including elevation and pachymetry maps, to avoid misdiagnosis or missing early disease.
When we evaluate corneal topography, we can identify different patterns that help us distinguish between normal corneas, regular astigmatism, and keratoconus. Starting on the bottom left, we see a symmetric bow tie pattern, which represents regular astigmatism. This is characterized by two evenly distributed areas of steepening on either side of the vertical meridian. As long as the bow tie remains symmetric, it is considered a normal finding. As disease progresses, the pattern can become asymmetric, with one lobe larger than the other. This often corresponds to inferior steepening, shown in the red box on the top, which is one of the earliest signs of keratoconus. With further progression, the radial axes of the bow tie become skewed, which is seen on the bottom right. This IS asymmetry and skewing greater than 21 degrees are highly suggestive of keratoconus. On the far right, we see a clinical example of a keratoconus topography map. Notice the intense area of red and orange colors inferiorly, which represent significant inferior steepening, along with clear skewing. The irregular, asymmetric bow tie pattern confirms the diagnosis.
Now let's move on to tomography, which is an essential tool for detecting and monitoring keratoconus. Tomography can be performed using slit scanning devices, such as Scheinflung imaging systems like the Pentacam, or with anterior segment OCT. These technologies provide a three-dimensional map of the cornea, allowing us to evaluate both anterior and posterior corneal surfaces, as well as corneal thickness. Key tomographic features include isolated elevation islands, which may be seen on either the anterior or posterior surface. Importantly, posterior elevation is often one of the earliest signs of subclinical keratoconus, appearing before anterior changes are evident. We also look for abnormal thinning, typically defined as less than 500 microns, which often coincides with these elevation islands.
a significant IS thickness difference greater than 30 microns within the central 5 mm zone around fixation is strongly suggestive of keratoconus. Another clue is a greater than 30 micron difference in thinnest pachymetry between the two eyes, highlighting the asymmetry of the disease. In addition, the location of the thinnest point is important. In a normal cornea, this should be centrally located. A decentered thinnest point, typically inferotemporally, is concerning for keratoconus. Finally, tomography helps us track changes in pachymetric progression, where we often see abnormal thinning in the periphery in keratoconus patients. Together, these tomographic findings allow us to detect early disease, confirm clinical suspicions, and monitor progression over time.
This figure shows a Scheimpflug-based corneal contour map, which gives information about the anterior curvature, top left, corneal thickness, bottom left, anterior elevation, top right, and posterior elevation, bottom right, which highlights several classic tomographic findings in keratoconus. In the upper left, we see a power map demonstrating inferior corneal steepening with relative superior flattening, a hallmark pattern of ectasia. Moving to the upper right, there is an isolated island of anterior elevation above the best fit sphere, which coincides with the area of maximum steepening. In the lower right, we observe an isolated island of posterior elevation, another early and sensitive indicator of keratoconus. Finally, in the lower left, there is marked corneal thinning in the same area that corresponds with both the steepening and the elevation changes. Together, these four maps illustrate how tomography provides a comprehensive assessment by combining curvature, elevation, and pachymetry data to confirm the diagnosis and assess the severity of keratoconus. This slide demonstrates tomographic findings in early-stage keratoconus using slit scanning images. In the upper left and upper right panels, we see anterior and posterior elevation maps, both showing significant elevation above the best fit sphere. The lower left image displays a power map, where there is clear skewing of the radial axes, a classic sign of irregular astigmatism that is strongly suggestive of keratoconus. Finally, the lower right pachymetry map reveals decentered thinning of the cornea, with the thinnest point not located centrally but instead coinciding with the area of steepening and elevation. This constellation of findings highlights the utility of tomography in detecting subtle and early keratoconic changes, even in asymptomatic patients such as this case who was being evaluated for LASIK consultation. This slide demonstrates Scheimpflug-based tomographic imaging in a case suspicious for early corneal ectasia. In the upper left map, we see an asymmetric dumbbell pattern with inferior steepening, but notably without skewing of the radial axes. This suggests irregular astigmatism, but not the typical keratoconic pattern. The upper right image shows an elevation map with astigmatism present, but importantly, there is no abnormal anterior elevation detected. Moving to the lower left map, the pachymetry distribution is shown to be decentered, although overall corneal thickness remains within the normal range. Finally, in the lower right map, there is abnormal posterior elevation that coincides with the location of maximal thinning. Taken together, these findings suggest a process consistent with early ectasia. In addition to keratometry, topography, and tomography, other ancillary tests can play a role in the diagnosis and monitoring of keratoconus, however, are not commonly used in clinical practice. Anterior segment OCT allows us to assess corneal thickness distribution and epithelial patterns. In a normal cornea, the thickness is greatest centrally and decreases superiorly. In contrast, a keratoconic cornea shows characteristic thinning at the apex and thickening supraonasally. Wavefront aberrometry analyzes higher-order aberrations of the optical system. In keratoconus, the most common higher-order aberration detected is coma, reflecting the asymmetric distortion of the cornea. However, other aberrations, such as trefoil, may also be present. These measurements help explain why patients with keratoconus often report poor visual quality even when standard visual acuity is relatively preserved. When evaluating keratoconus, serial imaging is necessary. A single snapshot in time may not reveal whether the disease is stable or progressing, so repeated measurements allow us to track changes in corneal shape, thickness, and vision over time. On devices like the Pentacam, staging can be performed using the Berlin ABCD grading system, which is based on 4 key parameters: anterior curvature, posterior curvature, pachymetry at the thinnest point, and best corrected visual acuity. This system provides a more comprehensive assessment than keratometry alone. Another key consideration is the risk of corneal ectasia following refractive surgery such as LASIK or PRK. Certain risk factors increase susceptibility, including young age, high myopia, a thin residual stromal bed, thin corneas, or an abnormal corneal contour. A useful clinical pearl is that young patients with unusual corneal topography who are being evaluated for refractive surgery should always be carefully screened for keratoconus or early ectasia. Even subtle irregularities may predict future progression, making these individuals poor surgical candidates until stability is confirmed. Now let's take a closer look at the histopathology of keratoconus. One of the hallmark findings is iron deposition in the basal epithelium at the base of the cone. This creates the Fleischer ring, seen clinically, and is indicated in the top right figure, marked by the arrowhead. In the same picture, breaks and fragmentation of Bowman's layer can be noted, often with fibrous tissue ingrowth filling those defects. This structural weakening contributes to corneal thinning and protrusion, and the black arrows demonstrate these areas of disruption. In the middle picture on the left, we see thinning of both the corneal stroma and the overlying epithelium. This stromal thinning is progressive and directly responsible for the cone-shaped cornea we observe clinically. Finally, the bottom right images show the changes that can be found in Descemet's membrane, including folds labeled D and breaks labeled E. These defects are especially significant in cases complicated by acute hydrops, where tears in Descemet's allow aqueous fluid to enter the stroma, causing sudden edema. Together, these histopathologic findings explain the progressive biomechanical instability of the cornea in keratoconus. When it comes to the management of keratoconus, we start with conservative treatments. In the early or mild stages of disease, glasses may be sufficient to improve vision, but their effectiveness quickly declines as corneal irregularity increases. Contact lenses can significantly improve visual acuity by neutralizing corneal irregularities, but it's important to remember they do not halt disease progression. As keratoconus advances, corneal scarring and contour distortion can limit both vision and contact lens fit. Rigid gas-permeable, or RGP lenses, are the most commonly used. However, scleral lenses are becoming increasingly popular because they vault over the cornea, providing both comfort and stable optics. Other options include soft toric lenses, bicurved or hybrid designs, piggyback systems that combine a hard lens over a soft lens, as well as mini-scleral and fully custom scleral lenses. On the right, you can see a comparison of corneal topography and photokeratoscope images. The top left image shows the corneal shape without a contact lens. Note the irregular axial map and the distorted reflection rings below it, indicating surface irregularity. In contrast, the top right and lower right images show the same eye with a contact lens in place. The axial map becomes smoother, and the reflection rings are now regular and concentric, demonstrating how contact lenses can correct the optical irregularity and improve vision. Lastly, patient counseling is critical. Advise patients to avoid eye rubbing and to manage allergic eye disease or atopy, since both are known to accelerate keratoconus progression. Now that we've covered conservative measures, let's move on to surgical and advanced management options for keratoconus. The first option is mechanical debridement or phototherapeutic keratectomy, PTK. These procedures are used to remove subepithelial scarring, which can improve contact lens tolerance and vision. However, it's important to note that scarring can recur over time, so this is not a definitive solution. Next, we have intrastromal corneal ring segments. These are small arc-like implants placed in the corneal stroma to flatten and regularize the cornea, seen in the picture on the top right. While they can improve contact lens tolerance and reduce irregular astigmatism, they are not disease-modifying and do not halt progression of keratoconus. The most important disease-modifying treatment is corneal cross-linking. This is considered first-line therapy for progressive keratoconus, especially in younger patients and adolescents, where it has been shown to halt progression very effectively. It works by using riboflavin and UVA light to strengthen collagen crosslinks in the cornea.
Of note, it is less effective in advanced keratoconus or in post-LASIK ectasia. It can also be performed in combination with ring segments for a synergistic effect. Finally, for advanced disease, we consider keratoplasty. Indications include poor vision despite well-fitted lenses, lens intolerance, unstable fit, progressive thinning near the limbus, or non-resolving corneal hydrops. The two main types performed are PKP, which remains the gold standard and offers excellent prognosis, and DALK. The benefit of DALK is that since it spheres the endothelium, it avoids the risk of endothelial rejection, although the risk of stromal rejection and thus scarring can still occur. PKP is generally preferred when high-quality donor tissue is available, but DALK is an excellent alternative in the right context. Let's wrap up the section on keratoconus by talking about the management of acute corneal hydrops. The first line of treatment is hypertonic agents such as Muro 128. These are used for several months and help draw fluid out of the cornea, thereby reducing the edema. We can also use topical steroids, cycloplegics, and bandage contact lenses. Steroids help reduce the associated inflammation, cycloplegics relieve ciliary spasm and pain, and a bandage lens provides comfort during the acute episode. Aqueous suppressants are sometimes added to decrease the amount of fluid entering the cornea by reducing aqueous production, which helps minimize swelling. Another more interventional approach is the use of intracameral gas, such as sulfur hexafluoride, SF6, or perfluoropropane, C3F8. A non-expansile gas bubble acts as a temporary barrier to reduce fluid ingress and can accelerate the resolution of hydrops. However, we must be cautious of pupillary block. Measures like pupil dilation or performing an inferior peripheral iridectomy may be needed to prevent this complication. In cases where hydrops does not resolve or when it results in visually significant scarring, keratoplasty may ultimately be required. So, hydrops management is stepwise, starting conservatively with hypertonics and supportive therapy, moving to intracameral gas if needed, and finally considering surgery if the episode leaves visually debilitating scarring. Now let's shift gears to talk about another common cause of corneal ectasia, pellucid marginal degeneration.
Pellucid marginal degeneration, or PMD, is a rare, usually non-hereditary disorder characterized by bilateral peripheral corneal thinning without associated inflammation. Its exact cause remains unknown, but it is considered part of the ectasia continuum, showing overlap with keratoconus. In fact, although unusual, PMD can very rarely coexist with keratoconus in the same eye. Clinically, PMD tends to present between the ages of 20 and 40 years, and it affects men and women equally. Patients typically develop high, irregular astigmatism, which results in progressively decreased vision. The hallmark finding is a 1 to 2 millimeter wide band of inferior corneal thinning, located about 1 to 2 millimeters from the limbus, spanning roughly from the 4 o'clock to 8 o'clock position. An important distinction from keratoconus is the location of corneal protrusion. In PMD, the cornea protrudes just above the thinned zone, creating the so-called beer belly appearance. In contrast, keratoconus protrusion occurs at the actual point of maximal thinning, usually in the paracentral or mid-peripheral cornea. Other features include the absence of corneal vascularization or lipid deposition, which helps differentiate PMD from inflammatory peripheral thinning disorders. Posterior stromal scarring may be present in some cases. Complications can include acute corneal hydrops, as seen in keratoconus, due to sudden breaks in Descemet's membrane, and in rare cases, spontaneous perforation of the cornea.
This slide demonstrates the hallmark clinical findings of PMD. On the left image, we can see a striking inferior corneal protrusion just above a band of inferior thinning. This protrusion creates the characteristic beer belly appearance that distinguishes PMD from keratoconus, where protrusion occurs at the actual point of thinning. On the right image, a slit-lamp cross-section highlights the inferior stromal thinning, located 1 to 2 millimeters above the limbus, with associated protrusion above this area. This slide demonstrates the topographic features of PMD. One of the hallmark patterns seen on corneal topography is the crab claw configuration, which represents peripheral inferior corneal steepening. However, it is important to note that this pattern is not pathognomonic, as it can also be observed in cases of inferior keratoconus.
The distinction between PMD and keratoconus can often be challenging since both disorders fall within the ectasia spectrum and may show overlapping features. For this reason, differentiation requires correlation not only with topography but also with elevation and pachymetry maps. These additional imaging modalities can help confirm the presence of the characteristic band of inferior thinning in PMD, which is absent in keratoconus. Looking at the figure on the right, we can clearly see the classic crab claw pattern on corneal topography, with symmetric areas of inferior steepening that resemble the pincers of a crab. This topographic sign, combined with clinical findings of peripheral thinning, supports the diagnosis of PMD. This table provides a comparative overview of peripheral corneal thinning disorders, PMD, Terrian marginal degeneration, Morin ulcer, and furrow degeneration. PMD typically presents between ages 20–40 years with blurred vision and astigmatism. It is non-inflammatory, has no systemic associations, affects both sexes equally, and is often bilateral but asymmetric. The classic thinning occurs inferiorly without epithelial defects, vessels, or lipid deposits. Terrian marginal degeneration generally presents after age 40 with a male predominance. The thinning is most often superior but can be inferior, and vessels cross the thinned area. It is usually non-inflammatory, although a subset can be inflammatory. Lipid deposition occurs at the central edge of thinning. Morin ulcer is distinguished by being painful, inflammatory, and progressive. It may be associated with hepatitis C or helminthic infections. It can present in young patients as severe and bilateral, or older patients, typically milder and most often unilateral. Thinning typically involves the nasal or temporal cornea, extending circumferentially or centrally. Epithelial defects are typical, and vascularization occurs at the periphery of the ulcer. Furrow degeneration is usually seen in older adults and is characterized by a circumlimbal thinning within the arcus. It is non-inflammatory, bilateral, and asymptomatic. No vessels or lipid are present apart from the arcus, which is always seen. In summary, PMD and Terriens are generally non-inflammatory ectasias, Morin ulcer is painful and inflammatory, and furrow degeneration is a benign age-related thinning. In PMD, the epithelium, decimate membrane, and endothelium typically appear normal. The key histopathologic finding is stromal thinning accompanied by focal disruption of Bowman's layer. Unlike Terrian marginal degeneration, there are no associated lipid deposits. Management depends on the stage of disease. In early stages, contact lenses are used, though fitting is more difficult compared to keratoconus. Scleral lenses are most commonly employed, with hybrid lenses occasionally considered. In advanced cases, surgical intervention may be necessary. Both PKPs and DALCs can be used, though grafts often need to be large and located near the limbus, which makes surgery technically challenging and increases the risk of rejection. Alternative approaches such as wedge resection and lamellografts may also be considered. Adjunctive therapy with corneal cross-linking may provide benefit in selected cases, though its role remains limited. Lastly, let's discuss keratoglobus. Keratoglobus is a rare, bilateral, non-inflammatory corneal ectasia characterized by a globular-shaped cornea and marked peripheral thinning. It is typically present at birth and is usually not inherited. Clinically, the condition presents with a globular corneal contour, a deep anterior chamber, and a slightly increased corneal diameter. Diffuse corneal steepening and thinning occur, with thinning most pronounced in the periphery. This differs from keratoconus, where thinning is focal and located in the inferior paracentral region. A potential complication of keratoglobus is spontaneous rupture of decimates membrane, which can lead to acute corneal hydrops. Unlike keratoconus, keratoglobus is not associated with atopy, contact lens wear, iron lines, stress lines, or anterior scarring. However, it is often linked with systemic and structural abnormalities, such as prominent folds or thickening in decimates membrane, blue sclera, and connective tissue disorders, including Ehlers-Danlos syndrome type 6 and osteogenesis imperfecta. The image shown highlights these features, with the cornea appearing abnormally globular and the periphery markedly thinned, serving as a classic visual example of this condition. Ancillary testing plays a critical role in diagnosing keratoglobus and assessing the extent of corneal changes. Scheimpflug-based imaging is particularly valuable, as it can highlight both steepening and thinning patterns across the cornea. In Keratoglobus, power maps typically demonstrate diffuse corneal steepening, seen in the bottom right picture, while thickness maps reveal extensive areas of marked thinning, as noted by the top figure. The Scheimpflick cross-sectional image shown here on the left further illustrates the corneal protrusion and diffuse thinning, capturing the exaggerated curvature that characterizes the disease. The color-coded pachymetry and curvature maps to the right confirm these findings, with areas of red and orange indicating zones of extreme thinning and steepening. Taken together, these ancillary images provide a comprehensive overview of the structural instability in keratoglobus, and they emphasize the importance of imaging in both diagnosis and monitoring progression. Keratoglobus may represent a defect in collagen synthesis, and histopathologic evaluation reveals several key features. These include an absent or fragmented Bowman layer, a thinned stroma that nonetheless maintains normal lamellar organization, and a thin deciment membrane. Management strategies depend on disease severity. In early cases, contact lenses, particularly scleral lenses, can be helpful, although fitting is often challenging. Unfortunately, the prognosis for PKP in keratoglobus is poorer than in other corneal ectasias, given the extensive thinning and fragility of the cornea. Lamellar keratoplasty, sometimes followed by PKP, may be considered as an option for vision preservation. Because patients are at high risk for spontaneous rupture, protective eyewear should be strongly emphasized. In children, high myopia associated with keratoglobus should be managed with spectacles to reduce the risk of amblyopia and optimize visual development. Now that we've finished our overview of ectatic disorders, we are going to finish this chapter by learning about two procedures used in the management of keratoconus and related conditions: intrastromal corneal ring segments and corneal cross-linking. Intrastromal corneal ring segments, or ICRS, are small circular arcs made of PMMA that are surgically implanted into the posterior mid-peripheral corneal stroma. They are primarily indicated for patients with mild to moderate keratoconus who have developed contact lens intolerance. While ICRS are not a cure, they may significantly reduce disease progression and improve functional vision. Importantly, they are not indicated for subclinical disease and are only occasionally used in pellucid marginal degeneration, PMD. The mechanism of action involves mechanically flattening the cornea, thereby reducing irregular astigmatism and improving contact lens tolerance. The refractive effect is greater when thicker segments are implanted or when they are positioned closer to the visual axis. In the United States, the FDA-approved device is Intax, whereas Ferrara rings and Kera rings are more commonly used outside the U.S. An advantage of ICRS is that they are reversible. If adverse events occur, the segments can be removed, and thus reversing their effects. Additionally, they are often removed about a month prior to keratoplasty if transplantation becomes necessary. The accompanying figure illustrates the placement of intrastromal corneal ring segments within the corneal stroma, showing how the arcs are symmetrically positioned to flatten and regularize the corneal contour. This visual highlights their role in reshaping the cornea mechanically to improve visual quality. The indications and contraindications for Intax implantation in keratoconus are important to understand before proceeding with this surgical option. Intacs are generally indicated in patients with progressive vision loss that is not correctable with glasses or contact lenses. Eligible patients are typically 21 years or older with a clear central cornea and a minimum corneal thickness of 450 microns at the incision site. Furthermore, Intacs are considered when the only alternative option is corneal transplantation, with the aim of delaying or potentially avoiding the need for a graft. On the other hand, there are several contraindications. Intacs should not be implanted in patients who expect to be completely glasses or contact lens free after surgery, as the procedure does not eliminate the need for visual aids. Contraindications also include cases with mean keratometry readings greater than 58 diopters, central corneal scarring, or corneal thickness less than 450 microns at the incision site. Systemic conditions such as collagen vascular, autoimmune, or immunodeficiency disorders are also relative contraindications, as they increase the risk of poor wound healing or complications. Additionally, certain ocular conditions like recurrent erosions, herpetic keratitis, or corneal dystrophies predispose to complications and should be avoided. Finally, the use of isotretinoin, which can interfere with wound healing, is also considered a contraindication.
The design and instrumentation of intact segments are tailored to reshape the cornea in keratoconus and other corneal ectasias. Each segment is constructed as a 150-degree arc with a fixed inner diameter of 6.8 millimeters and an outer diameter of 8.1 millimeters. The thickness of these segments ranges from 0.25 to 0.45 millimeters, available in increments of 0.05 millimeters, with the degree of visual correction being directly proportional to the thickness of the implanted segment. The surgical technique begins with the creation of a radial incision, typically performed superiorly using a diamond knife. Through this incision, channels are fashioned within the corneal stroma using a suction ring and lamellar dissector. Alternatively, a femtosecond laser can be employed, which allows for the precise creation of both the incision and stromal channels, reducing variability and enhancing safety. We will go into more detail about surgical technique in the next slide. Imaging guidance is an essential component of this procedure. Technologies such as Scheimpflug imaging or OCT pachymetry maps are used to measure corneal thickness, ensuring appropriate channel depth. This step is critical as it helps reduce the risk of intraoperative perforation, a potential complication of the procedure. When performing intrastromal corneal ring segment surgery, pachymetry is first measured at the incision site. A diamond knife, set to 60 to 70% of stromal thickness, is used to create a 1 mm radial incision. Channels are then fashioned at the 7 mm optical zone with either a suction ring and lamellar dissector or with a laser. The ring segments are inserted at a depth of 60 to 70% and rotated into position, and the incision is closed with glue or sutures. Creating narrower channels can increase therapeutic benefits, but it also makes ring insertion more technically challenging. There are surgical variations to consider. Options may include 2.35 mm segments, a thicker inferior ring, or the use of a single segment. A single inferior segment is sometimes oriented toward the steepest portion of the cornea, which flattens the adjacent cornea but may steepen the superior cornea, a phenomenon often described as the beanbag effect. Tailoring the number and thickness of segments to topographic findings can provide better physiologic outcomes. When intrastromal corneal ring segments are combined with corneal cross-linking, the rings should be implanted first. Channel creation becomes significantly more difficult once cross-linking has already been performed. Correct placement of intrastromal corneal ring segments is crucial for achieving the intended biomechanical effect on the cornea. In this slit-lamp image, we can see the ring segment properly positioned at approximately 70% stromal depth. Placement at this depth provides stability while minimizing the risk of superficial extrusion or deeper perforation. Ensuring correct alignment allows the ring to exert the desired flattening effect on the cornea, improving astigmatism control and enhancing contact lens fit, while also reducing complications related to malposition. This visual emphasizes the precision required during the procedure to optimize outcomes. The next slide is a video from the AAO that shows surgical placement of intrastromal corneal ring segments.
Hello, this is Dr. George Waring from Charleston, South Carolina, discussing the use of intracorneal ring segments with a femtosecond laser. Here we've marked the geometric center of the cornea, and we're applanating the femtosecond laser based on the geometric center. We're doing a femtosecond-enabled lamellar channel creation. This is based on a 75% depth of the thinnest pachymetry at the 7 mm optical zone. Now we're doing a blunt dissection through the side cut down to 75% to find the proper lamellar dissection, and then we'll use a posterior angle when we insert the intacs. We always do the larger segment first, which is typically the inferior if this is a decentered inferior cone, and we're going to gently advance, making sure that we're in the proper location through the femtosecond laser enabled channel. We can finish the insertion with a blunt nudge of the insertion forceps and or a Sinskey hook. Again, here we're going to use a superior intac. We're using a 0.210 millimeter superior intac and an asymmetrically implanted 0.450 inferior intac. Here again, we're gently advancing, taking care to make sure we're in the proper plane. We're finishing the implantation with a blunt nudge from the insertion forceps, and then I'll use a Sinskey hook to enter the channel and to put this into its final resting position. We'll close with a single interrupted tenonylon, rotate the suture, and then we'll place a bandaged contact lens. Now, when we examine the patient immediately postoperatively under the slit lamp, we can ensure that the patient's implants are at approximately 75% of the corneal depth using a slit beam. This has been George Waring from Charleston, South Carolina. We hope that you've found this video presentation informative and useful. Thanks for your time and attention.
ICRS implantation has demonstrated meaningful outcomes in both visual improvement and long-term stability. In terms of visual outcomes, patients often experience better uncorrected distance visual acuity, or UDVA, and best corrected visual acuity, or BCVA, although most still require additional optical correction to achieve optimal BCVA. The procedure enhances contact lens tolerance and proves most effective in cases of moderate keratoconus, particularly when keratometry values remain below 58 diopters. It also helps reduce inferior corneal steepening, coma, and the IS ratio on corneal topography, which translates into improved corneal regularity. Looking at long-term stability, a study involving 85 keratoconus patients revealed that 93% demonstrated no further progression between 1 to 5 years after implantation. Importantly, no significant differences were noted in mean keratometry, UDVA, or BCVA across follow-up visits, indicating that the procedure effectively maintains refractive stability over time. ICRS has also been explored in the context of post-LASIK ectasia, where Intacs have shown the ability to reduce myopia and improve UDVA. However, the long-term efficacy in this subgroup is less established, leading to its classification as an off-label treatment. Special caution is advised when implanting in eyes with a lamellar interface, as this may increase complexity and risks. Postoperative corneal topography provides valuable insights into the effects of Intacs implantation. As shown in the figure, the preoperative topography, lower left, demonstrates oblique steepening, while the postoperative topography, upper left, reveals contraction of a steep cone after placement of a single segment Intacs outside the cone. The difference map, seen on the right, which subtracts postoperative from preoperative measurements, highlights flattening over the ring segment, blue areas, and persistent steepening in the overly flat region, red areas. Overall, this shift moves the corneal apex closer to the center, illustrating how Intacs can reshape corneal architecture and redistribute corneal curvature to improve visual function. Complications of ICRS can be divided into general complications and severe visual symptoms. In terms of general complications, approximately 1% of patients experience a loss of 2 or more lines of BCVA within the first year after surgery. Even if BCVA is preserved, the overall quality of vision may still be negatively impacted due to subtle distortions or irregularities in corneal optics. More notably, around 14% of patients report severe visual symptoms, which are frequently associated with larger pupil diameters. These symptoms include night vision difficulties, blurred vision, and diplopia. Patients may also experience glare and halos, particularly in dim lighting conditions, as well as fluctuations in both distance and near vision. Photophobia is another common complaint in this group. Other adverse events, listed below, occur in about 1% of patients. These events may include anterior chamber perforation or anterior corneal perforation during or after surgery. Another potential complication is microbial keratitis, which poses a significant risk to vision if not promptly treated. Additionally, implant-related issues can arise, such as migration or extrusion of the ring segments, as illustrated in Figure A, where the implant has visibly extruded through the anterior cornea, resulting in an overlying epidefect. Improper placement, particularly when the ring segment is positioned too shallowly, can also occur and compromise surgical outcomes. Over time, corneal thinning directly over the ring segment may develop, as shown in Figure B, where localized thinning over the implant is evident. Complications of ICRS extend beyond general and surgical risks. Around 11% of patients at 12 months post-op experience ocular complications such as reduced corneal sensitivity, induced astigmatism ranging from 1 to 2 diopters, or deep neovascularization at the incision site. This is demonstrated in Figure A, which shows vascular growth extending toward the implant. Other reported complications include persistent epithelial defects and inflammatory reactions like iritis or uveitis, which may require careful management to preserve corneal integrity. Another notable finding is the development of postoperative deposits, which can occur in up to 74% of cases. These lamellar intrastromal channel deposits, shown in Figure B, are thought to arise from corneal injury and keratocyte activation during healing. While these deposits are visually striking, they typically do not compromise visual outcomes or the overall functional success of the procedure. The last and final topic on today's lecture is corneal cross-linking, or CXL. Corneal cross-linking is a treatment first introduced in 1997 as the Dresden protocol and received FDA approval in 2016 for patients aged 14 to 65 with progressive keratoconus or post-refractive ectasia. The most widely used method is epi-off CXL, where the corneal epithelium is removed and the underlying stroma is saturated with riboflavin, or vitamin B2. Once riboflavin has penetrated the cornea, the eye is exposed to UVA light. The cross-linking occurs due to the interaction between oxygen-free radicals generated by the combination of riboflavin, oxygen, and UVA light, which induce cross-links between collagen fibrils. The outcome is increased corneal rigidity and a slowing of ectasia progression. Riboflavin plays a dual role, not only enabling the cross-linking process but also protecting deeper structures from UV damage. In its presence, up to 95% of UVA light is absorbed within the anterior 300 microns of the corneal stroma. To prevent endothelial injury, the minimum stromal thickness after epithelial removal must be at least 400 microns. The image on this slide demonstrates full-thickness, homogeneous stromal penetration of riboflavin during CXL, with the bright green fluorescence highlighting even distribution throughout the corneal layers, though notably absent from the anterior chamber. This visualization underscores both the effectiveness and safety of riboflavin absorption in limiting UV penetration to vulnerable posterior structures. The main purpose of corneal cross-linking is to slow down or stop the progression of corneal ectasia, particularly when it is detected in its earlier stages. By stiffening the corneal structure through the riboflavin-UV interaction, the procedure helps preserve vision and prevent further deterioration. However, it is important to emphasize that cross-linking does not eliminate the need for glasses or contact lenses, as most patients still require optical correction for functional vision. Cross-linking is considered the first-line treatment for mild to moderate ectasia, making it the cornerstone intervention for stabilizing disease progression before more invasive procedures are needed. To monitor the course of disease and the effective treatment, several metrics are proposed. These include mean and maximum keratometry values, steepening of both the anterior and posterior corneal surfaces, the thinnest pachymetry reading, and the rate of change in corneal thinning from the center toward the periphery. Additionally, the degree of refractive astigmatism provides valuable information about both disease progression and functional visual outcomes. The surgical technique for corneal cross-linking follows a structured protocol designed to maximize effectiveness while ensuring safety. The first step is epithelial removal, where the central 9 mm of the corneal epithelium is removed using the PRK technique. This allows better penetration of riboflavin into the corneal stroma. Next, riboflavin loading is performed by instilling a 0.1% riboflavin solution in 20% dextran every 2 minutes for 30 minutes. Adequate stromal saturation is confirmed at the slit lamp by observing riboflavin fluorescence in the anterior chamber. A corneal thickness check using ultrasonic pachymetry is then carried out to ensure safety before UVA exposure. If the exposed stroma measures greater than 400 microns, UVA irradiation is delivered for 30 minutes, with riboflavin instilled every 2 minutes to maintain saturation. If the thickness is less than 400 microns, a hypotonic riboflavin solution is applied every 15 seconds until the cornea swells to at least 400 microns, after which standard UVA treatment is initiated. Following the procedure, a post-treatment regimen is prescribed. This typically includes topical cycloplegic drops, antibiotics, and corticosteroids, along with the placement of a bandage soft contact lens to promote epithelial healing. Some clinicians also add a topical NSAID twice daily for 2 days to help control postoperative discomfort. The accompanying image shows a treated cornea under UVA light, with radial red lines serving as a guide for the surgeon. These lines help ensure the correct distance between the UVA source and the eye is maintained throughout the procedure, ensuring uniform exposure.
The outcomes of corneal cross-linking have been well studied, with multiple long-term trials demonstrating its ability to halt the progression of keratoconus. These studies show improvements in both uncorrected distance visual acuity, UDVA, and corrected distance visual acuity, with a greater relative improvement in UDVA. Additionally, reductions are observed in keratometric values, which reflect corneal steepening, though astigmatism reduction tends to be minor and spherical equivalent remains largely unchanged. One notable epi-off study evaluating 241 eyes revealed a reduction in corneal steepening of approximately minus 2.68 diopters at 1 year and minus 4.84 diopters at 3 years. BCVA improved by at least 1 line in 75 eyes during the first year and in 19 eyes by the 3rd year, supporting the long-term effectiveness of the procedure. The impact on keratoplasty has also been significant. European studies suggest that the need for keratoplasty in keratoconus patients has decreased since the introduction of cross-linking. While this reduction may also reflect concurrent improvements in contact lens technology, it underscores the role of cross-linking in delaying or preventing the need for corneal transplantation. Several prognostic factors influence outcomes. Patients with mild to moderate keratoconus have a better prognosis compared to those with advanced disease. Younger patients, however, tend to experience faster disease progression, necessitating closer monitoring and earlier intervention with cross-linking. In contrast, patients with post-LASIK ectasia often face a worse prognosis, likely due to reduced biomechanical stability from the corneal flap. Corneal cross-linking, though highly effective, carries several contraindications and potential complications that must be carefully considered before proceeding. Relative contraindications include patients with corneal thickness less than 400 microns, although some protocols permit treatment at thicknesses greater than 300 microns. A history of prior herpetic infection is also a risk factor, as UV exposure may reactivate the virus. Severe corneal scarring or opacification, poor epithelial wound healing, severe ocular surface disease such as dry eye, and underlying autoimmune disorders are additional conditions that may make cross-linking less suitable or riskier. Possible complications are varied. Some patients experience photophobia or delayed epithelial healing after the procedure. Corneal stromal haze, which may be visually significant, can develop, and there is often a temporary decrease in corneal sensitivity. Infectious keratitis and sterile infiltrates are less common but serious risks, while in rare instances, patients may develop corneal melting or persistent corneal edema due to endothelial damage. The table included in the slide summarizes complication rates associated with epi-off CXL. Among 117 eyes followed for 1 year, approximately 2.9% of patients lost 2 or more lines of best-corrected visual acuity, while 7.6% experienced disease progression. Sterile infiltrates were observed in 7.6% of cases, and central stromal scarring occurred in 2.8%. Importantly, the overall complication rate was around 1%. When we think about corneal cross-linking, it is important to recognize that while the Dresden epi-off protocol is the most widely used and FDA-approved method, there are several alternative techniques under investigation or in clinical use. One such option is transepithelial or epi-on CXL. In this approach, the corneal epithelium remains intact, which translates to less pain for the patient and a lower risk of complications compared to epithelial removal. However, because the intact epithelium acts as a barrier, riboflavin penetrates the cornea less effectively, reducing treatment efficacy. To compensate, higher UVA energy may be required, since the epithelium can attenuate radiation reaching the stroma. Another strategy is accelerated CXL, which leverages new generation UVA lamps designed to deliver treatment in a shorter period. Rather than the standard 30-minute exposure, accelerated protocols using high-fluence UVA can be completed in as fast as 5 minutes. A study that used high-fluence UVA at 7 milliwatts per square centimeter over 15 minutes showed comparable outcomes to the traditional Dresden protocol, making accelerated cross-linking an attractive option in busy clinical settings. Finally, there are combined techniques, often pairing cross-linking with other interventions such as intrastromal corneal ring segments or PRK. The idea here is to not only stabilize keratoconus, but also to improve visual outcomes. Notably, same-day PRK combined with CXL appears to be more effective than performing the procedure sequentially. However, patients must be counseled carefully about the risks, particularly the potential for progressive ectasia following PRK. It is worth noting that while promising, these combined techniques have not yet seen wide adoption in the United States.
Thank you for your attention and engagement throughout this chapter. By understanding the pathology, diagnostic testing, and treatment options of various ectatic disorders, as well as advanced techniques like intrastromal corneal ring segments and cross-linking, you are now better equipped to appreciate the complexity of these conditions. The ultimate goal is always the same: preserving vision, improving quality of life, and giving our patients the best chance for long-term stability. Stick around while we finish with a 10-question quiz. See you in the next chapter.